Hello, and welcome to Beyond the Limb, where we explore physical therapy evidence, expertise, and innovation in limb loss and limb difference care. I'm your host, Will Riddick, and I'm a physical therapist focused on patients with limb loss and limb difference. The Veterans Affairs Amputation System of Care is one of the most comprehensive limb loss care models in the world. It serves as an excellent model for coordinated interdisciplinary care and is well backed through research and clinical practice guidelines. Today, we're going to explore what makes it work and what any physical therapist can learn from it to improve care for their patients. My guest today is Patty Young, the National Program Manager of the VA Amputation System of Care, who oversees a nationwide network of interdisciplinary teams supporting veterans with limb loss across the entire continuum of care. Patty, thanks for being here.
Thanks for having me. Happy to be here.
To kick us off, can you tell us a little bit about your kind of clinical background? You yourself are kind of interdisciplinary here.
I am a physical therapist at a Northeastern University. I graduated in 2002. I'm also a certified prosthetist out of Cal State Dominguez Hills, which I finished that coursework in 2007 and have been a certified prosthetist since 2009. My experience as a PT has been mostly in the inpatient rehab setting. It's my favorite setting to be in. I kind of like all the challenges and enjoy the patients and getting to know the patients and their families. It's always been my favorite. I've definitely spent time though in acute care, in ICUs, in day rehab, and also in outpatient clinics. I did spend my 1 year as a prosthetic resident in the Philadelphia area, which I loved. And then after I moved back east, after working at University of Michigan, I joined the VA in 2010 as the amputation rehab coordinator in Richmond, VA. So the Richmond VA is one of the 25 centers of the amputation system of care where there's specialty teams, and the amputation rehab coordinator position was open. I was the last one hired on, and that was back in 2010. And then in 2019 is when I moved into my current role as the national program manager of the amputation system of care.
Nice. That's awesome. Yeah, and you've kind of been there sort of through this whole really kind of through the whole thing almost.
Yeah.
Um,
Oh, yeah.
kind of we're going to talk a lot about the amputation system of care, obviously the whole model of it, but could you kind of like sort of define it like on a broad level what kind of makes it tick, what components are there, all that.
Sure. Yeah, definitely. So amputation system of care, it was created back in 2008, 9-ish. The intent was to prepare people from a clinical side for that influx of people who were coming in with amputation from what they were perceiving to be an influx from the post 9/11, but also to care for the baby boomers who were those who were developing diabetes and having complications and ending up in amputation. And then even as far back as those from World War II and Vietnam who were living with amputation. They really they did a deep dive and determined that there wasn't comprehensive care for these individuals. So that's what amputation system of care does. So there's 25 sites that are sites of centers of excellence, and then over 115 more where there are amputation care teams, meaning that they have a prescribing provider and a therapist and a prosthetist at the very least. And those individuals stop what they're doing all the other days and have a day or half a day or however many days of an amputation clinic. And the goal is to look at the patient in a comprehensive manner. We try to get to them from pre-amputation, but also to provide that comprehensive care throughout their lifetime. And it's kind of like a spider web or scaffolding across the country in the sense that there's sites all over. So if a veteran needs more specialty care, they can move up the tiers to the higher level of expertise. But also, should they move, change locations, we can make sure that they're still in the system and that their care isn't dropped. So it's kind of like a communication spider web too.
That's awesome to have like access wherever they are, wherever they need to
Yes.
be. That's super cool. um yeah, as that's quite a bit to try to tackle that much kind of care, I guess, provision across the entire country. What are some strategies that you all use to try to kind of bring in like a sort of a consistent quality of care or that high quality access to care?
Yeah, that's something actually we really strive to address. The biggest part of our attempt, or the main focus, is training clinicians and making sure that the message we provide to veterans is consistent across the country. So we hold annual trainings in various regions, and we try to invite all persons, all teams from that area. And that includes the physician, it includes the therapist, it includes the prosthetist, it even includes the person in the background who does the administrative stuff to get prosthetics through the system. So we try to bring them as a team to these trainings. Um, the trainings themselves, because they're only once a year and only in regions, we still try to keep consistent education across the continuum. So we have monthly education series. So it's every third Tuesday of the month, and we invite our DoD colleagues, our civilian colleagues, our academia colleagues, and then of course those within the VA. And then we provide a lot of guidance documents. So we have clinical practice guideline, we have guidance documents galore for everything you can imagine, from virtual amputation care teams to provision and prescription of adaptive sporting, equipment and prostheses. And we just try to keep um, people abreast of all of the great things that are happening and make sure that they have a place to go for it. So we have a very extensive internal SharePoint where people can go. It's like a library of all the things they need. And then I think in addition to that, we just do a really good job of connecting with people. We have meetings, monthly meetings. Everyone has my email, everyone has my Teams, everyone knows they can call me. And then my job is I'm like a matchmaker. I kind of set people up. Oh, you should know this person on that side of the country and let me call them. So there's a lot of connection to create collaboration. So I think clinicians feel supported. And then I think that's why veterans see us as a collaborative group, or like a well-oiled machine in many ways, at many of our sites, because we all work together and we do it in the best interest of the patient.
Yeah. I'm thinking about the clinical practice guideline, the most recent one that was released, the VA DoD. Speaking of the lower limb one, particularly, that was released, and it referenced the amputation care team, which, if I'm not mistaken, is pretty much exactly model that you're describing, if I'm not mistaken.
Yes, it is the model we're describing. And I think it's similar to what is used in the DoD as well. And I honestly think it should be used all over the world, because you can't look at someone with one set of eyes, right? You have to have all parties, because we're complicated people, we're humans. So I think people's experience requires the experience of many others treating them. So, yeah.
Yeah, for any listeners who have not looked through that document, there's even good summary documents that are kind of like shorter versions, that you're not having to read the ridiculously long uh
Yeah.
protocol of how
And
it was all done and everything
oh,
like
yeah.
that. Yeah,
And then we did add more charts too. I don't know if you've seen that,
that's
but this
true.
time around we added a lot of charts so people could just have it right up in front of them and go through the chart. So I thought that was helpful. I'm a visual person though, so I kind of like that part.
Where was that your contribution or part of your contribution to
That
that?
was one of my contributions.
Got
I'm
it.
like, we
Nice.
got to have something quick and easy, something that people can pull out and kind of take with them. You know what I mean? Because who is going to look through a 223-page document for something?
Yeah.
You can search a word, but there's a lot going on there. So,
Yeah,
yeah,
that's clinical translation right there.
there it is.
Yeah.
Exactly. Yeah.
So kind of we've talked about this idea of like the whole interdisciplinary stuff. We've got this kind of broad team that covers so many different aspects. Um, how would you just say that like the amputation system of care covers like the continuum of care? So let's say like either somebody who had some kind of trauma, either that's combat related, or if that's kind of like a chronic health condition, something along those lines. From there to maybe like full continuum back in the community, long term health. What does that
Yeah.
process look like as somebody who's going through the system?
Yeah, I love that question. I think that's something that we do well. We try to get in touch with them and in contact with them as soon as we find out they exist. So fortunately, we have like recovery coordinators, care recovery coordinators. So maybe it's a social worker, or maybe it's a nurse in our DoD settings, or for those who are transitioning into um, VA, and they usually give us a heads up. They know our map. They have our list of people to contact, and it usually starts with one of those 25 um, amputation rehab coordinators at one of those 25 sites. They're kind of the point person, and then from there they would contact. So, for example, I'm in Richmond, and when I was the amputation rehab coordinator, if someone, let's say, was in Durham, Durham is in my neck of the woods or my vicinity. So the person would tell me this veteran's information, and I would then reach out to Durham and say, "You got a new guy coming at you. Here's a few, a bit of information. Call him, welcome him. So we try to pull him in that way. It's actually my favorite thing to do is to call veterans. I get to still do it a little bit now, and I can always tell when I've kind of a little happier and more joyous when I get to talk to someone like a veteran. It's just, because I don't get to see patients as much anymore and more admin, so it's really fun to chat with them. And then we also connect locally with for those who from a disease process perspective, those who are maybe they've tried to save their foot for the last 16 months and they just can't do it anymore. And they've tried everything and wound care and podiatry and hyperbaric and blah, 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 blah. They just can't do it. So the nice part about that is so many of our sites, of those 140 plus, I would say the majority of them have some connection to wound care team locally, podiatry locally, ortho locally, vascular, because we make sure that those individuals know that we're present and that we're ready for the handoff. So it's a lot of education, and that's what we do is educate patients. So no, they're scared if they're going to have an amputation. They're scared. They're overwhelmed. They don't know what just happened. So we spend that time educating them, kind of putting their mind at ease, answering the questions they have. And then we watch them grow as a person, as a patient, as a user, as a maybe a wheelchair user, or maybe not a prosthetic user, or as a prosthetic user. And then we see them all the way through to their end of life, which also means watching them age and maybe some changes. Maybe they're not wearing the prostheses that's the super fancy. Maybe they're not using the manual wheelchair. Maybe they move into a push assist or a power chair. So that's how we kind of continue to move with the patient and to see the patient from the beginning all the way to the end.
Yeah, that's really cool. For I would say probably the majority of physical therapists that are kind of working with the population, you know, um, we can look at this model and say like super cool, but maybe don't work in that particular setting.
Right,
But I
right.
think especially as you've been talking about this idea of like almost like the local kind of connections, the local team, I could see a lot of kind of like overlap with like what PTs could potentially take and kind of try to implement in their own sort of community. So let's say we had potentially a listener to this, or even myself as I try to do one of these kind of teams outside of that system. Um, what kind of I would say lessons or what kind of areas would you point a therapist that might ask you this question of how do I start to begin making a team like this or an interdisciplinary team in my own community from the providers that are here locally?
Yeah, that's a really good question because having been in the civilian world for so long and then coming into the VA sort of like, oh, duh, it just makes sense that this is in place. But we forget that it requires some, massaging of schedules and some collaboration and creation of a community. Um, you know, I feel like this has to be an organic situation with people who you work with on a fairly regular basis who share the same ideals as you. And maybe that's where that clinical practice guideline comes in handy, right? People are reading it and they keep seeing amputation care team. It's like, oh gosh, who is this team? So maybe that's what the benefit of the CPG will do. Who knows? I can only dream. But it would be to see people adopting that approach to the care of a person, because as a physical therapist we see many different things about a patient than the physician, than the prosthetist, right? And even when we pepper in social worker, a nurse, you know, maybe a therapeutic recreational specialist or an occupational therapist, all of these people look for different things and that team effort. So I would say start with finding your people. Like, who is a physician you love to work with? Who is a social worker you love to work with? Who is a prosthetist you love to work with? And then kind of trying to find a way to get everyone in the same room, I guess. Maybe start with like some case study discussions or something and see how people get along and work together. I don't know. It's a good question. I'd like to see it everywhere.
Yeah, no kidding. um, Yeah, I think that's kind of been a common theme with some kind of previous discussions we've had and uh, prior episodes is this idea of connecting with local providers. So I think when we're looking at stuff like this, it's potentially, you've got referral sources. So you've already has physician names potentially in your chart or coming to you like on a piece of paper right in front of you. And I think that's kind of an early connection point. You have a patient that's coming in and maybe they have a prosthetic limb. Who made that? Who's doing that? And to be able to you know, that have them be part of that care team because they already are. They may not be collaborative in that same process.
Right,
You may not be having discussions, but they're already a part of the care team,
right.
whether you're talking to them or not.
Right. And it behooves all of you to work together for the benefit of the patient, right? So it would be kind of a cool opportunity if you can feel them out, check it out, see whether that's something of interest. And maybe it starts a little low level, nothing crazy, and a few discussions. And then in the end, maybe it's something that's a more regular, more normal, scheduled meeting or something. So,
Yeah.
yeah, cool. Yeah, it's a good idea.
I want to talk about some of the kind of other elements within the amputation system of care. So, there's a couple things that we had kind of sent some message back and forth about. One of these I think is a pretty recent thing. It's actually being more represented in like physical therapy today is like virtual care.
Mm,
Kind of
I
curious
feel that.
about how you all do virtual care
Yeah.
and what that looks like.
Yeah, it's actually my favorite topic, which is hilarious because I never in a million years would have thought that would have been my favorite topic before. But so virtual care for us. So I started in December of 2010, and we had our very first virtual appointment in May of 11. And a crazy history, a bit of history. The VA did their very first virtual clinic back in the 60s in Nebraska, which I saw the
What?
pictures. I know, I was like, "Wait, what is this?" But what was bonkers is they knew that there was a reason for this, and the machine was the computer, and I say the machine because it was like a screen and then this enormous it, like, took up an entire room,
It's got
but
like
they
the
did
tubes
it
and everything.
because oh, yeah, all the
Yeah,
2
yeah, yeah.
like, a little mouse inside doing its thing, but, like, they actually had it where it was between I believe it was between the University of Nebraska and the Nebraska like, the Omaha, Nebraska VA or something, and so what's crazy about it is that it and I don't know what the person, I mean, who knows? It was probably like a simple visual inspection of something. And that's probably what they couldn't get the person out of the hospital for whatever reason, maybe. But now we've done so much to adopt it, even starting back in 2011. So it's kind of funny because when the world shut down with COVID, everyone was freaking out. Oh my gosh, we're not going to be able to see patients. And the amputation system of care was like, we can. We know what we're doing. We've been doing this for years. So, and it's funny because I think the original motivator to doing virtual care was, as you know, there's only so many VAs, right? There's a lot of them, but there's only so many.
Yeah.
So it's hard to get people to travel a pretty long distance. So we have these things called CBOCs. They're like clinics, community based outpatient centers. So they're clinics. And people would drive to their CBOC instead of driving all the way down to the VA. So think of a spider, the body of the spider as the VA, and the ends of the legs as the various CBOCs. So people could drive to the ends of the legs and not have to schlep all the way into the VA. So that's really how we started. We were motivated to save travel dollars for the VA and also to save time and energy for patients, because we knew a lot of our patients were not in the best of shape. And so to get them into the car and have them drive 3 hours, it's like, and the wife is looking at you like, please don't make me do this again. And we're like, no, no, we won't. We'll come in. We'll come to you. So that's how it started, is that they would go to the clinic. And then we expanded to dropping into their house or dropping into their outpatient, their community prosthetic partners office, where they would go see their prosthetist and we would beam in and the prosthetist and the patient would be sitting right there. So the VA really, especially the Amputation System of Care, has really done a great job of adopting virtual care just across the continuum. So it's pretty awesome. I have so many good stories. So many good stories.
I'm curious because I think, for folks who've been at least in practice, having gone through
Mhm.
the pandemic and everything closing down,
Right.
and probably I think many of us had tried to do some element of virtual care. I remember
Yeah.
sitting in my guest bedroom, like laying on the bed, demonstrating
Yeah.
exercise to patients.
Exactly. There's a lot of that.
It was like it bringing people into your home is a whole
Yeah.
life experience. But
Your kid runs in
yeah,
or
that's right.
something.
Yeah.
Yes.
But I was kind of curious, in terms of like physical therapy services, what does that virtual care look like? Kind of take me into an appointment and what that might look like for them.
So, so a lot of what we do from a physical therapy standpoint for amputation stuff is, and what I like about doing PT in the home is I like to see where they live, not because I'm a creeper and I'm trying to see what they have in their house, but it's really like so many people do exercises, right? We give them their home exercise program, and then you have no idea what that actually looks like in their home because you don't know where they're setting themselves up, right? And we've all heard horror stories of, oh, I tried to do that exercise and then the chair I was sitting on flipped, and you're like, oh Lord. So it's kind of nice to be in their home and to help them problem solve where they can do the exercises. So I
Mm.
feel like that's always the biggest thing. And then we go through the exercise program demonstration. Absolutely 1,000% of it is you standing up and finding a space in the PT space and showing them how to do the exercise. And then I would say, okay, now bring me to where you think you're going to do that and let me see the space. Let me make sure it's, safe and appropriate, and let's practice it. Put your phone on the ground and let me see how you do this. So it was a lot of that. It's also, as you know, I mean, it's not just the exercises with the population of individuals with limb loss. It's socket checks, sock management. It's let me see that part on your leg again. I just want to make sure it looks okay. So it's sort of a more holistic um, approach to care other than just Therex. You know what I mean? So yeah, so there's definitely, yeah, it's a little all the many facets of checking on your patient. I mean, I once had we did an amputation clinic meeting to this patient at home, and his wife said, can you call us and let me just he's in the bathroom, and the gentleman was actually getting out of the bathtub. And I'm not joking, he was literally taking a bath. So he was not closed at all. And everyone on our team was like, ah, but I was like, no, no, wait, watch him get out of the tub. Like, does he get in the tub by himself? She's like, oh, yeah. And it doesn't look good. And I'm like, ah. So from that came occupational therapy consults, which ended up in DME and ended up now he is a safer transfer. So you sort of see things that you're like, I think I should ask about that quick. So it's a good thing. So you never know what you're going to find when you go virtually into someone's home. So yeah, it's pretty
It's
funny
like one
though.
of those like wild stories, but it's like also like absolutely clinically amazing because
It
like
totally makes sense. Exactly.
you addressed an issue that probably nobody else would have caught or
Right,
noticed because of
right.
that. Even
And
though,
his wife said, "Oh, he does that all the time." I'm like, "Oh God, how has he not hurt himself? Like,
yeah,
how is this the first time we're seeing this?" But really, I know, and everyone else in our clinic was like, "Ah." And me being the PT, I'm like, I need to see that again. Can you do that again? I'd like to see that. So, yeah. So we find our time. PTs are everywhere. We can do everything.
Yeah.
So,
As we were talking, we've kind of talked about this kind of like idea of like holistic care overall.
yeah.
So certainly that also kind of goes into things like peer support kind of
Oh,
things.
yeah.
How is that kind of done within the amputation system of care?
Yeah, so that's a good segue actually from the virtual because we offer a lot of virtual support groups. Not just because of the pandemic, but because of the distance. Some sites may have, I don't know, I think support groups kind of wax and wane a little bit. Sometimes you have a group that's really chatty and loves to get together, and then maybe people move, maybe people pass, maybe people move on, and then the group kind of gets smaller and then it gets bigger again. And so it's a waxing and waning. So we actually do a lot of support groups across the country, across state lines to allow people to connect and be together. We were holding, and I don't know if we're still doing it. I think we are in the Philadelphia area. They have an all women's support group, so we do provide and try to provide that support wherever it's needed. And then we work with the Amputee Coalition. We have a really strong partnership with them, and we have about 40 clinicians who are trained to be certified trainers. So I myself am a certified trainer. So I was
Mm.
actually just at the AC conference out in January for a day to provide training to 13 people in becoming certified peer visitors. And so we have a network of that too. I don't know our number right now, but I would say it has to be over 70 veterans who are certified peer visitors. And then we currently use Teams, Microsoft Teams, and we have a little Teams channel that if you have a veteran with a certain kind of need or a certain level of amputation, maybe they're a certain age, a certain hobby, we put it out there, kind of like an APB, and say, hey, who has this? And someone writes and says, oh, I have a veteran for you. I'll connect you. So we really do we kind of see the country as, yes, it's a big country, but we try to make it feel smaller by connecting people wherever they are, regardless of their location.
Yeah, super neat. I like that.
Yeah, it's cool.
The whole way of like connecting people and
Oh yeah, it's like a dating app or something. Just kidding. We should put one of those together. But yes, it's kind of like that. We're like, I've got a guy who loves that. I've got someone like that too. We should get them together. It's so funny. But it's so cool to watch people like, oh, whoa, you're calling me from California. That's wonderful. Like, and it's really sweet. So it's fun to watch the connection.
I love it. Yeah, and also a great way of using kind of the virtual connections and
Oh yeah.
crossing, yeah, areas. Yeah, that's one of the things I think. So for me, like I work in outpatient, and for me,
Right.
transportation is usually one of the largest barriers.
Yeah.
So the system I work in, we have an inpatient kind of a readmission program where we have people come in for intensive prosthetic training, and we also offer it on the outpatient side too. But um, you take somebody who does live 3 hours away from a
Yeah.
specialty center, an inpatient thing you could do because you got a place to stay. You've got
Right.
consistent,
Right.
resources around you. Whereas that outpatient sector is definitely challenging. So I think the idea of like
Right.
being able to connect with virtual peer visitors, connect with virtual supports, I think
Right.
that's exciting for sure.
Yeah.
So, um, yeah. So I kind of want to also talk about within the VA. I know for a fact you all do a really good job with like connecting people with like activity, with sport, with
Oh yeah.
recreation.
Yeah.
Talk a little bit about how that goes.
Yeah, we actually have done a really big push since I guess it's kind of back to 2022. So yeah, 22, 23. Um, we started really putting our energy and efforts behind um, making sure that veterans were aware of the awesome opportunities to participate in adaptive sports and sporting events. So we partnered with the National Veteran Sports Programs and Special Events team, and they have 7 events over the course of the year, and they're all so different yet similar. Like they all offer sort of the same concept of that feeling of belonging and competition and connection, but they all also are different in their own right. So, for example, there's the National Veterans Golden Age Games. So that was one where there were only, I think, 3 people who, or 5 people who attended with amputation. And so years ago. So now what we've been doing is trying to encourage people. Golden Age Games, the only requirement is that you're 55 or older.
Oh, yeah.
And so it's like, hi, whatever, you can do that. Why can't you do that? You're a great walker. You can even function, very well in a wheelchair. You can attend and be at the wheelchair level. So it's getting people there. And I think the hardest part is people go, I can't travel to Tampa. Like, well, why
Mhm.
not? Like, well, I've never done it before. It's like, well, maybe this is your new experience. So that's when we pull in our colleagues who are certified therapeutic recreational specialists and we say, hey, I think this guy is the real deal. We should get him involved. And so that's kind of how we do it. And we provide, beauty of the VA is we provide veterans with the equipment that they need as well, as
Mhm.
long as we don't do it willy-nilly. It requires training and an effort from the veteran on their part as well. But we make sure that when they do go, let's say they do go to the National Veterans Wheelchair Games, that they have an awesome wheelchair that is prepared for participation in sports. And let me tell you, those events, those people do not mess around. It is gloves off, like hardcore competition. So it's pretty awesome, actually. So yeah, so it's really, really, really a cool place to be and to see people um, not identify as the person living with limb loss, but rather they're an athlete and they're there to win. And it's like, oh, okay, well, sorry, I didn't realize. Okay, good luck. So it's intense. It's awesome. So, and the smiles on their faces and the connection is so cool.
Yeah,
So
definitely.
yeah, yeah.
I think, the whole idea of, like, travel especially is, like, a really whole
Oh yeah.
that's a conversation for another day of the
Oh
podcast
yeah.
for
Oh
sure.
yeah. Oh yeah.
But you referenced what you referenced is the AC conference, the Amputee Coalition conference. I had a
Yeah.
colleague that went, and she was even talking about how, like, people were getting around, people were, accessing it, and there are so many great resources out there,
Yeah.
for folks. So yeah,
Yeah.
anyways. Um
Definitely.
yeah, so let's say we've got a PT that you're talking to, or somebody's listening right now, and they're saying like, I'd love to do this. I've got some basic ideas. What would you be some good resources you might hand somebody to them to kind of start down this path?
For down a path of getting patients
Promoting
in
the continuum of care,
wellness.
promoting a care
Yeah, I love that.
team, all that kind of stuff.
Yeah, yeah, yeah. Again, I think it's talking to people. It's bending people's ear to find out what people like how they connect with patients, how they might. I mean, talk to your patient. Start with your patient. You said it before. Your patient has a leg. Well, that leg had to have been made by someone. So find out who that person is, right? And then find out I say veteran, what your patients likes and interests are, right? If they love to bowl, well, then let's find you someone else who can bowl with you. And we are fortunate in Richmond. We have an incredible organization in Richmond that helps people get back to sports, right? But like those organizations are everywhere. And I hadn't realized it, but they are everywhere. You just have to look for them. And so I would encourage therapists to jump online and look for the various events and the various activities they want to see their patients participate in. And then from there, you meet people. Again, it's about connection and networking. Like Project Healing Waters, for example, is a nonprofit organization that connects people who want to learn to fly fish. But it's not just that, right? Maybe you don't love to fly fish, but maybe you like to regular fish. Well, maybe you'll meet people there who like to do traditional fishing as well. And then maybe you'll even find people who want to do something else just like you want to do. So I don't know. I think it's the power of having a conversation with people and not, face to face, in person, connect and find your likes and dislikes. And you should do that as a therapist too, because I think that's where you have to, you know, kick some doors down and talk to people just to make sure that you find your connection. So,
I think you've kind of laid out a great example of caring for a patient is not just like the therapeutic exercise. It's not
Oh
just,
gosh, yeah.
you know, taking him through whatever the plan of care is going to be. It's being
Yeah,
present with him. It's listening
right.
to what's going on. It's maybe watching a video of them getting out of a bathtub. You know,
I do
it's
prefer if you would have been closed, but
yeah,
that makes sense.
exactly.
But yes, but yeah,
But there's so many it is a thing that we wanna approach very holistically to kind
yes,
of, to capture so much and bring them back to, enjoyment, of so much of what they do, and that
right,
includes so many disciplines in order to make that happen. So even
right,
ones we haven't necessarily talked about, like you mentioned recreational therapist, occupational therapist,
right.
you know, yeah, I mean, even I think you could get to like rehab psychology, all these kinds
Yeah,
of fields too.
yeah. Oh
So
gosh, yeah.
to kind of wrap up, this is probably a hard question. I feel like this is
Mm.
always it's a great question, but it's I feel like it's a hard
Uh-oh.
question to kind of pare down. Do you have a person that comes to mind when you think of somebody who has really represented and like benefited from the system that you kind of oversee? Like somebody that sticks out and like they're kind of a brief
Like a
story.
particular patient?
Hmm.
Oh gosh, yeah. Raymond, I'll never forget him. Honestly, he was a really incredible example. He's unfortunately he passed back in I think 2021, 2020. Um, but um, he had developed frostbite and was very ill. He was living with a friend, but that friend was not kind to him. And so he would oftentimes spend time at night outside. Um, and his cousin, who was basically like a sister to him, was called and made the decision to have his legs amputated. He was not around, he was unconscious. He was not in a good space. Um, so she amputated his legs. And I remember him coming to clinic, and he was really quiet anyway. But he didn't really want to connect with anyone. He sort of wanted to keep us all at a distance. And one day we were in clinic, and he said, I just wish that she'd let me go. Like, I wish she hadn't chosen. And we were there and we all listened and we talked through it and we got the rehab psychologist in and we just made sure that it was a communication, the lines of communication were open. Well, after that, I think the trust factor was high because he saw that we were a team that really loved him. So fast forward, we bring him into amputation rehab boot camp, which is what you were referring to when they come inpatient. We call it a boot camp or comprehensive boot camp in the VA because of the boot camp. But so he came in and he's bilateral above knee and we got him stubbies. But the stipulation was he wanted to get out of the house he was in with the friend who was not such a friend and get into a space that was going to be his own and safe for him. But how was he going to do this from a wheelchair level with stubbies? So he and his sister worked together to find him a place to live. And then they furnished it. And it was like his first place of his own for years and years and years before that was the last time he had been in a space like that. Then he came to our rehab and he came for 25 days. And this is a guy who didn't smile much and was like really quiet. Well, by the end, people were like, we're going to miss you so much. Nurses, doctors. I mean, the people who do like environmental management in the hospital were like, going to miss this guy. He just was a great person. We just kind of needed to pull him out of his shell. So then someone says to him the second to last day, I have an idea. I think you should go to the National Veterans Wheelchair Games. And he was like, what are you talking about? I'm not going there. I can't get on a plane. I've never been on a plane. She's like, ever? He's like, no. She's like, done. We're doing it. So, I mean, she's amazing. She's like one of my favorite, CTRSs. She's amazing. And so she got him to go. And he came back with medals. He medaled in 9 ball. He got a gold medal in 9 ball from wheelchair 9 ball.
Oh my gosh.
It was awesome. And we all heard that he was coming to see us, and we made posters and signs all in the hallway. And it was like a parade, like a Super Bowl parade, like a World Series parade. And he came onto that unit, and we were all there, and we're like, wow, and screaming for him. And he had tears and a smile. People were like, we didn't know he smiled like that. It's like, I know. So his quality of life was so much different after amputation. And that's what he kept saying. He's like, I never thought that this was going to be a good thing for me. I thought this was the end. He's like, and instead it was the end of the old me and the beginning of the new me. And
Wow.
it was really amazing. I have his picture still framed. He was like by far my favorite. Raymond was the best. And we all felt it when he passed. It was, yeah, it was definitely a factor. Telling the nurses on that unit that he passed was, oh God, it was worse than telling my kids when our dog died.
I
They were like,
imagine,
"What?"
yeah.
So, it was really, yeah, he's really awesome. So, I would say a situation like that is we kinda pulled all the resources that we could to make sure, so social work helped with his housing and, CTRS and OT and PT, and we took him out on outings to get him ready for the wheelchair stuff and the airport stuff, and it just was such an incredible experience. He really felt like he had lived a totally different life, which was awesome.
I
So,
think when we talk about, like, what we covered in, like, our discussion, you know, it's a lot. It's a lot to go above and beyond to try to dig into what's going on in a patient's life, to seek out other providers. That those are not maybe typical everyday clinician things probably. I
right,
would say it's a higher calling for sure.
right.
But I think it's something that we should strive for. And for folks who when you're seeing that, you hear this and you're like, "Oh my gosh, I gotta do this too. I gotta reach out to them. I gotta do that. I gotta connect with these people." But then you hear stories like this, and it's like,
Yeah,
it was all worth it. Like, to go and
puts
do
smile.
that. It's like, if you do that once, it is all worth it to have it
Oh,
for a patient like that.
1,000%. Yeah,
So,
I agree. And I think PTs do a good job at that, though. I think we do a good job of while we're stretching them and maybe causing them a little discomfort while we're doing we try to distract them with, "So, tell me about your favorite color," you know? And then we do get to know things about people, and I think that as long as we kind of follow our gut to go with it and to kind of try to provide them an opportunity to regain some sort of independence or return to some function or activity. I think that's really big. So,
yeah. Well, Patty Young, National Program Manager of the VA Amputation System of Care. Thanks for being here.
thanks for having me. I really appreciate this, Will. This was fun.